I should go ahead. Very good afternoon to everyone. So I'll be presenting my topic on cataract surgery in rheumatoid arthritis and severe dry eye. Rheumatoid arthritis is an autoimmune disease that classically presents with symmetrical polyarthritis with diverse extra-articular manifestations. Though it is primarily a rheumatologist's domain, yet the ophthalmologist's role comes when these patients present with ocular manifestations, which include dry eye disease, episcleritis, scleritis, PUK, and rarely choroiditis and vasculitis. Coexisting dry eye in RA becomes significant even more when these patients present for visual blurring associated with cataract. So according to a recent meta-analysis, dry eye disease is the most common ocular manifestation of RA with an estimated prevalence of 16%. The spectrum of ocular surface disease due to KCS in RA ranges from mild to significant keratopathy with varying degrees of ocular surface scarring and ocular surface inflammation. There is primarily lacrimal gland dysfunction along with meibomian gland dysfunction and severe goblet cell deficiency. Adding to this, surgical trauma itself can initiate a progressive immunological response. So it is of prime importance that the surgeon is aware about the risk of post-op exacerbation of dry eye disease, heightened inflammatory response, and subsequent sterile corneal melt and perforation. Hence, the treatment of RA and ocular surface disease should be optimized prior to any ocular surgery. Perioperative stepping up of immunomodulatory therapy should be considered in such patients. So there are many challenges when we take up these patients for cataract surgery. There is reduced accuracy of the measurements. There is blurred vision, which is erroneously attributed to cataract at times. There is poor media clarity, post-operative exacerbation of underlying immunoetiology, and there is poor healing response and suboptimal outcomes. Hence, a preoperative evaluation becomes essential, which includes examination of the eyelids and adnexa through the tear film and cornea and conjunctiva also. Keeping in view the Delphi panel recommendations and the TFOS DUCE 2 reports, which includes triaging questions to identify systemic diseases, ASCRS has put forth an algorithmic approach to either rule in or rule out ocular surface diseases prior to planning of cataract surgery. So if OSD is detected, we need to further assess if it is visually significant. If it is not visually significant, as seen with normal cornea and topography and no surface staining, we can proceed with routine cataract surgery. However, in the case of visually significant ocular surface disease, keratopathy, there is irregular astigmatism and fluctuating vision, surgery may be planned only after optimization of the ocular surface. So, whenever the patient comes for the first visit, he may be handed over a questionnaire, first as indicated by ASCRS, followed by non-invasive measurements. It is preferred to obtain biometry prior to any invasive test in an undilated pupillary state. Scan should be repeated till minimal variation is reached. Following this, the assessment of dry eye disease for tear volume, tear film stability, and ocular surface integrity is essential. So in a routine clinical setting, we can do Schirmer's test, tear film breakup time, and ocular surface staining. Then clinical examination is done using the LLPP technique. Then we come to immediate preoperative and intraoperative measures. So phacoemulsification is the preferred technique for most cataract surgeries due to its minimally invasive nature and of course faster visual recovery. And the use of drops preoperatively has to be minimized as they are known to cause blepharitis and ocular surface inflammation. We should restrict our use of povidone iodine to 1 drop only, and we should avoid the use of preoperative non-steroidal anti-inflammatory drugs. We should always see that we are doing clear corneal incisions, and we should avoid touching the conjunctiva. And all the steps should be taken towards minimizing the surgical time. Then comes the retroillumination, which acts as a great tool for good visualization, as well as it reduces the microscope-associated phototoxicity. And there are surgeons who also avoid using forceps. Instead, we can use a Q-tip or a Vexel. Then at the end of surgery, we can put a BCL or coat with the remaining OVT. Effective post-operative care involves carefully managing the ocular surface to promote healing. Frequent use of preservative-free artificial tears, anti-inflammatory drops, punctal plugs, or immunosuppression is what does this thing. So close monitoring of ocular surface is essential to ensure smooth recovery. And if there are signs of poor healing, corneal thinning, or scleritis, rheumatologist also needs to be consulted for systemic immunomodulation. So to conclude, we should evaluate the ocular OST in cases of ocular surface staining. There should be an algorithm-based approach, preoperative optimization of ocular surface, and the cataract surgery should be customized accordingly. There should be use of non-preserved tears and adequate immunosuppression when necessary. Thank you.
Thank you, madam, for an excellent talk on covering the rheumatoid arthritis aspect and dry eyes in cataract surgery. Yeah.
What do you do when do you do biometry? What precautions do you take in this? Because to get a correct reading, how do you start these drops, artificial tear drops, a few days before taking this measurement?
No. Actually, if we have to take the biometry considerations, we have to see that the patient is totally naive. Patient's eyes are totally naive. He's not been administered anything. Then we have to see how the surface is actually. If the surface is, say, if we are getting the topography-based things, if we are getting variations, and if we are getting the Myers are distorted, then what we can do is that we can start the patient accordingly on the treatments. And when we get it smooth, then only we can go ahead with the biometry.
Fine. Thanks a lot, ma'am. We have the next